Good afternoon, everyone. I'd like to welcome you all to the boot camp today and introduce Dr. Dustin Long. He is the assistant professor of biostatistics and the co-chair of the CTSI's Clinical Research Design, Epidemiology, and Biostatistics program. He is also the biostatistician for the West Virginia Prevention Research Center. Dr. Long obtained his PhD from University of North Carolina, Chapel Hill. And we also have Dr. Baqiyyah Conway. She is a assistant professor of epidemiology and the epidemiology member of CTSI's Clinical Research Design, Epidemiology, and Biostatistics Core. She received her training from the University of Pittsburgh and Vanderbilt University by obtaining her PhD from University of Pittsburgh and a 3-year postdoctoral fellowship at Vanderbilt. Dr. Conway's research focus is at the end organ complications of diabetes.
Thank you all for coming to our talk today. So the title of this talk is Electronic Health Records for Research, or as research tools. And we're going to give a general overview of some of the benefits of EHR use in research, and then at the end we're going to talk a little bit about the resources that we have here at WVU and the WVCTSI. But in the middle, we're really going to focus on the epidemiological and biostatistical concerns that come along with EHR research and the things you really want to consider before you start using EHR doing your research projects. So that's kind of the focus here. But so a little bit of intro to EHRs. Electronic health records, they have the potential to be a resource for both large and small scale epidemiological studies. Why is that? Well, they're cost efficient for the researcher. There's a vast amount of data, of clinical data. We have the potential for less bias than a traditional clinical epi study because you have potentially large, I'll have to remember to do this, talk with this hand, potentially large populations that you're dealing with, large groups of people. And then hopefully, because it's a large amount of data, you have large translational ability, so it won't be subject to a small restriction. Some of the challenges with EHR research is determine who receives the usual care at the institution that provides the EHR data. Something that's termed, and we'll talk about later, called catchment area, or the population of interest. So we'll come back to that later. Also, accounting for or acknowledging area or period effects. When we talk about our EHR here, we're going to talk a lot about when those data are collected, when they're available. So you need to understand when you're doing EHR data, where did the data come from and what time period. Quality and data cleaning of the EHR data are of issue. Also, the development and validation of algorithms for selecting or stratifying on specific disease types and comorbidities. And we're going to talk quite a bit about that as we talk about our study. So the objectives today for this talk are to go through general limitations of EHR studies, which include defining your population, defining your exposure and your outcome, designing your study, and then most critically, and it kind of arches throughout all of this talk, are the data issues, including the structure of your data, both the EHR data and the data you use for analysis, cleaning of the data at both the EHR stage and your analysis stage, and then missingness of your data. So
for the backdrop for this talk, we're going to present 2 papers that we've been working on over the past few years, and this is work by Dustin and I and our colleague, one of our colleagues sitting back here in the audience, Matt Armistead. And so we'll be presenting 2 papers. One is one called Glycemic Control and Fracture Risk in Geriatric Patients with Diabetes, and the other one is called Validating the Extract, Transform, Load Process Used to Populate a Large Clinical Research Database. And so for this first paper, this is actually how Dustin and I met 3.5 years ago when we both started working here for the School of Public Health in the fall of 2012. And I was really excited. It was my first faculty position, and I could finally try to put in a grant. And as a junior faculty, you can't wait to try to put in that grant. It was my first grant, and as I'm an epidemiologist, and I had this readily available data set from, I had just come from a postdoc at Vanderbilt, and I had been working with Vanderbilt's de-identified EHR for the last few months there, and I still had access to the data, and I thought, wow, I could just use this data, because I didn't have any data here, I had just gotten here, to try to put in a grant. And so my mentor at the time matched me with Dustin, and then within 6 weeks we wrote this grant, and we submitted it, and it was about fracture risk in geriatric patients, looking at glycemic control levels. And didn't get accepted, but we thought, well, I didn't get accepted. We'll go ahead and write a paper from it. And so this is the paper. And, you know, that was fall of 2012. It's now beginning of 2016. It took a while. And that's what things happen. You guys can probably all relate to that. You start on projects. You put it aside for a while. You come back to it, put it aside. And that's sort of what happened here. But also, this paper was a lot of work. It was not the hardest paper I had writing, but as we come to later, it was the hardest paper I ever had to, when it comes to addressing it. And because it's an EHR project, I'm an epidemiologist, Dustin's a statistician, but this is clinical data from an electronic health record system. We don't know about that. And so we were very dependent on the clinicians. We had a clinician I was working with as well, and we were very dependent on the clinician on the project because it was his system. He knew the data, so it really involved, truly involved 3 people working together to put this together. And so I wanted to look at this. The reason why I wanted to look at this, a little background. So people with diabetes, elderly people with diabetes are at increased risk of fragility fractures. That means fractures due to like osteoporosis compared to people the same age without diabetes. And some reasons for that are hypoglycemia, so high blood sugar and the effects of high blood sugar on bone metabolism and the structure of the bone. Also low blood sugar, hypoglycemia, and how that can induce falls or fits because of the hypoglycemia, can cause like just trauma fractures. Then late complications of diabetes also affect bone metabolism. They affect gait, and that can cause falls and fractures. And then also just the pharmacological factors that may actually affect bone metabolism or dizziness or interact with other drugs and can also affect fracture. So these are all the things that are related to fracture risk in persons with diabetes. And so it makes it a little complicated. Another thing, so people with diabetes, the problem is they have high blood sugar, which causes complications of diabetes. And they've known that if you lower their blood sugar, bring it down to, we know this in at least younger persons with diabetes, if you lower their blood sugar, you can reduce a lot of the end organ complications of diabetes, like the eye disease, the blindness, the kidney disease, the nerve damage. You can reduce a lot of that by lowering their blood sugar. It's controversial about whether that's true in elderly people, but still, we know that. And so the American diabetes recommendations are that at that time, at least in the fall of 2012, were that you should have an A1C, and I'll get to that, less than 7% for most people with diabetes. That was the clinical standard recommendations, an A1C less than 7% for most persons with diabetes. However, we have a burgeoning population of elderly people, and a few years before that, they found that lowering glycemic control in elderly people might actually increase risk of heart disease. And so we're not sure about these glycemic control targets in elderly people. And so that's another reasons why we're looking at this. But still, the recommendations at that time were A1C of less than 7% for most. For very healthy people, even less than 6.5% should be the target. If those with short duration, and less stringent goals such as less than 8% for those who have a limited lifespan or some of the end organ complications of diabetes or comorbidities. But still, so they had specific groups, like they had specific guidelines for children, but they didn't have specific guidelines for the elderly. They were not specified as a specific risk factor group that you have special target guidelines at that time when we were putting in this grant. And so we wanted to see, is that 7%, less than 7%, is that actually safe for elderly people when it comes to fracture? And so our objective was to examine the relationship of glycemic control with the risk of fracture in elderly individuals with diabetes. And we defined elderly as 65 or older. And so we tested that both high A1C and low A1C might increase that risk of fracture. And so I got with my partner here, and I have this data set, and I'm like, can you help me do this, Dustin? I didn't really think I needed him, Because I've done my mentor. He says he says when you put in grants, the reviewers, they like to see a statistician on there. Well, I do all my own data analysis. What do I need him for? Just put him on there anyway. So we met. And some of you guys might feel that way. I know how to do data analysis. I don't need a statistician. I've heard that before from people coming into the clinics, and that's the way I felt. But anyway, I worked with him, and it turns out I really, really needed him, especially for this project, because when you get this data, so I got this data, and so. I'll come back to why I really, really needed him. So we sat down, and we used a synthetic derivative, and we're going to tell you a little about this. The synthetic derivative is sort of like our IDR here. We have the integrated data repository here for clinicians to use to do their research. Vanderbilt had the synthetic derivative. It contained over almost 2 million records, about 1 million of them with detailed longitudinal data, an average of 27 codes per record. And Dustin's going to step in here.
Just to give you an idea about the synthetic derivative at Vanderbilt, and this is fairly similar to some other large medical centers' EHR systems, and in fact this is there's going to be a picture that's a much simpler version of this for the IDR later on in this talk, and because this is the kind of thing we're kind of trying to build to here at WVU and WVCTSI. So what the synthetic derivative did is it collected data from, if you go from left to right, from the clinician in the clinic or the nurse or whoever's entered data in the clinic into one of their 3 systems that they had at the time. It goes into a system that then de-identifies them, and then it does some data parsing, so it's going to do a bunch of the work for you. Right? It matches that based off of the person's ID and a lot of these other criteria, not just hospital ID, but name and address and so on and so forth. And then it restructures it for research, and that's a key here, is that it is structured for research. It's taken clinical data and made it to where you still can do research. Then it goes into a database, and then you make requests, and then they generate you REDCap data. So that's the process. If you're a researcher at Vanderbilt, you would make a request, and this data processing all hers at the back end, and then you would receive a REDCap database all your own. So when we said earlier it was cost efficient, it's cost efficient for the researcher, but there are approximately 61 people that just work on the synthetic derivative in the background. So it's cost effective for the researcher. So one key feature of the synthetic derivative, which has actually been propagated into REDCap and some of these other systems, is this date shifting idea, so that you can de-identify people's data that you collected longitudinally, but still maintain your date relationship. So what happens is that the algorithm in the SD takes your first observation and subtracts up to 364 days from it. So if your first visit was at March 1st of 2010, it would randomly subtract something and it would become, say, April 19th of 2009. Well, then every subsequent visit you have is subtracted by that same number of days, so that I won't really know when the patient arrived in the clinic or arrived in the hospital, but I will be able to tell what was the difference in days from their first visit to their follow-up visit, or when they had a A1C measurement on this day, how long was it until they had an inpatient visit in the hospital? Okay? But it's still de-identified. And REDCap does that as well. If you de-identify a data set, it will do this same algorithm, because the same people created REDCap that worked on the synthetic derivative. But I'm stealing some of the thunder from the next boot camp, so I'll leave that for you all. So there's a lot of complication in the data before the researcher actually sees it, but it still maintains the research integrity, that it's de-identified, but we can still do research in a longitudinal or time-to-event kind of basis.
Okay, so I had this database, and so what we did is I selected 10,572 patients with diabetes. But I'll get to show you how we got down to that 10,572. How I did that is we simply I didn't use any fancy algorithm. We selected patients with an ICD-9 code for diabetes, and the ICD-9 codes which were 250 to 250.9. To be in our study, they had to be at least 65 years or older, and they had to have no missing data for HbA1c at or after the latter of age 65 or ICD-9 code for diabetes. Now, sounds simple enough. He and I spent a lot of time developing this. And this is where the study design comes from. We spent lots of visits, lots of times just sitting there thinking about how are we going to select the population? How are we going to define the population, define it in a data set? And that's where that study design, where the epidemiologist, you really need your epidemiologist for it. And we were both, so he and I felt like, wow, this is really, I wasn't thinking I was going to have to do this kind of study design, this type of thinking, working with EMR data, but we had to. How do I choose my baseline? How do I choose when, because the people aren't, I can't just say age 65 because, and they could have been in the EMR for many years. When do I define, when are they age 65? I have to choose at the time that they are age 65. So we spent a lot of time coming up with an algorithm, and this is what we came up with. So we started off with about 100,000 patients. Then we said, okay, not everybody has an age associated with that diabetes, that ICD-9 code. And so we say diabetic diagnosis, that meant their first, and we spent a lot of time thinking about it. What is diabetes diagnosis? Well, we thought, okay, well, let's just say their first ICD-9 code in the EHR for diabetes. And we thought, now how are we going to define their age? Well, now we had to think about that. Well, we know their date of birth. We have that in there. And we know the date of the ICD-9 code, so we just subtracted that to get their age of that ICD-9 code. But that's where the programming really came in, because when I got these data files, I was able to get these data files. They were not just, I didn't get it as a data set. I got large text files. I didn't know what to do with that. I'm not a programmer. I'm used to Excel files or SAS databases. I don't know what to do with a bunch of text files, just da-da-da-da-da. Fortunately, I had the statistician, and that's where he spent weeks programming it just to get it into like an Excel type file or a SAS data spread. I mean, I'm an epidemiologist. I can do data analysis, but I can't program like that. That's not what I was trained to do. But so that's what I'm saying. That's when I really, really needed him. So a big part of Dustin's role in this project has been the programming. And that's expensive. It's time intensive. And then later, but I'm not to denigrate one, because I did the initial data analysis. He served as he replicated my analysis, which made me feel secure that these results are correct. So that's also something you might want to have done too. But hugely though, he spent weeks, is that right, weeks? Programming it just to get it in a proper form. Programming it, cleaning it, all of that. So we came down, so he said, okay, we have 100,000 people with diabetes. We whittled it down. 500, we didn't have any age at time of associated with the first ICD-9 code for diabetes. We had to exclude them. Then when we did that, we thought, well, and then this is when it really became tricky. How do we define our baseline? So what's baseline? Well, we need an A1C. They need to have an A1C at the time of that first ICD-9 code for diabetes, and it had to be age 65 or older, so they could have been diagnosed before age 65. That's okay, but we're not looking at them until they're age 65. So if they were diagnosed before age 65, they're automatically in our system. We keep them. If they're diagnosed after age 65, we have to say, okay, well then the first time that they were diagnosed with diabetes after the age of 65, that's when they come into our group. Then they also had to have an A1C associated with that time point. And we said, well, it may not be one exactly. We thought, okay, let's just say within 6 months, we'll be happy with that. 6 months prior to that, up to 6 months prior to that, we'll be fine. But we had to really think about this. So we whittled it down some more. We got down to about 13,000 people. Then we thought, well, we're doing follow-up data, so we want more than just one. We thought we wanted more than just one observation after A1C. So we got rid of another 2,000 people who only had one A1C in the system out of that 12,000. So we whittled it down some more, and then we ended up with the 10,500. And so of those, approximately 1,000 had a fracture after they were diagnosed with diabetes, according to our criteria. And so this is how we came up with the system. But this is a lot of thought went into that.
So one thing I want to mention is that as you're sitting there trying to look at this flowchart, you're probably going, well, this is really complicated, and I'm kind of confused about all these decisions that you had to make to come down to your 10,000 number. And that is exactly true. And that is exactly one of the points that we're going to emphasize in this talk, is that when you're dealing with these large EHR data sets and you've got a lot of potential people that could go into, subjects that could go into your analysis, a lot of thought and a lot of work has got to go into creating that final data set. Right? Our final data set only had 10,000 in it. We started with 100,000. And then we needed to justify why we excluded every single person. We couldn't just arbitrarily say, well, these people don't look like how we want them to look, or they don't have some kind of variable. Well, if they didn't have a variable, we need to explain why, and that makes a huge decision in terms of our population of interest, and we'll come back to that later. So yeah, this was a large amount of work, and it's all on the analysis side, right? You saw how that framework, I told you 60 some odd people worked at Vanderbilt to get this synthetic derivative out to the researchers. This was all after those people had touched it and worked on it. This was all on our end.
So for our analysis, we use Cox proportional hazard models, and we use age as our time scale. And we evaluated baseline A1C. So we looked at their first A1C after they were diagnosed with diabetes and after the age of 65. And we also use what's called updated mean A1C. That means their average A1C values during the time of we're following them. So if they had like 3 A1Cs during the time that we followed them, we took the average of that, and that's the updated mean. And we looked at that and assessed it with fracture risk. We also looked, and we're going to come back to with this, we evaluated their most recent A1C associated with fracture risk because we wanted to see, well, we realized we really can't do that, but it was most recent A1C, if they had a low A1C around the time that they were fractured, maybe that would help us assess hypoglycemia. We ended up not using that, throwing it out, but that's what we did do those analyses. Again, baseline was defined as the first A1C at or after the ladder of age 65 or ICD-9 for fracture. I'm assuming most of you know what an A1C is. If you don't, your A1C is your glycated hemoglobin level, and that's what they use to monitor a person with diabetes, how well their diabetic control is, how well they're keeping their blood sugars. If they're keeping under control, they measure their A1C. So this is what the characteristic of our 10,000 people look like. This is what they look like. So they're on average about 72 years old. So it's a geriatric population that we define them that way. About half are female. Okay, so we're still doing pretty well here. Most were white. About another 15% were African American, and we had noticed this about 10% who were unknown, and that's separate from other race. And that's a huge problem in EMR data sets, is that you have this large population of unknowns, and part of that is simply because up until recently, you weren't necessarily, not everyone took down a person's race when they brought them in to see them. It could be that they didn't think it was necessary. They didn't even think about whether to take down a person's race. Now it's required, but they weren't always doing that before. So we have you can have up to some 15 or 20% in some EHRs with missing data. And that's going to change with time, so that's where the era effects also come in, the period or era effects come in. So you have earlier data sets that have more missing data, not necessarily early data sets, earlier in the EHR time period, you have more missing data on race. Later on, you have more complete data, so that may actually affect your analysis. But about 10% of our population had unknown race, and that was not, and they were actually an important population as far as A1C in relation to fracture risk. They were not similar to everyone else. But this population represented the Nashville area, so this is basically what Nashville looks like in general. This is what their A1C was. On average, their baseline A1C was about 7%, so they're in fairly decent control. Their average A1C through follow-up, they got better over time, a little lower, 7.2, and the last one was 7.1, so A1Cs are getting tighter with time. This is geriatric population, average just slightly obese on those that we had data for BMI. Notice though, almost 25%, almost a quarter, we had missing data on BMI. Now, when you fracture, BMI is important as it relates to fracture. That's an important covariate, covariate. It's also important too because we assume that every time a person comes in for a visit that you usually get your weight measured. So you think that that's sort of standard, but it's not happening all the time. In 25% we have missing data on that. So for them, we just gave them a 0 value when we're looking at the number of BMI measurements. And we used number of BMI measurements because we thought, I thought anecdotally, well, I know every time I took my grandmother to Vanderbilt, they weighed her. So I think that's just as a visit, because she would get her physician was there. She would go there for a visit. She was a geriatric patient. So I know they measure their weight every time they go in, whether they're sick or not. If they're a healthy visit or not, they go in. So I thought that will be a proxy for how frequently are they seeing their physician? How frequently are they getting these outpatient visits? So that's what we use it as a marker for. And on average, they're about 8. It ranged from, interquartile range is 1 to 21. So these were our results. What we found, looking at the first model is our base. The first model here is unadjusted for the number of BMI measurements. And we wanted to adjust for the number of BMI measurements because we wanted to account for people who were maybe hardly ever saw the physician versus those who saw their physician regularly versus maybe those who are even in the hospital. Is that going to affect our results? So unadjusted, what we found was that we used the A1C of 7 to 8% as the range, as a reference. An A1C of 6.5 to 7% was actually the safest, their optimal range for glycemic control as it relates to fracture risk. An A1C of less than 6.5% was no different than the reference, so it was not protective. So having an A1C of less than 6.5% was not protective of fracture risk. Higher A1Cs appear to increase the risk of fracture, particularly those with an A1C greater than 9%. But as you can see, when we account for our surrogate measure of how often they were seeing their physician on an outpatient basis, that high A1C value associated with it disappeared. So once we accounted for the number of BMI measurements, or a surrogate for patient-provider interaction, that risk associated with an A1C greater than 9% disappeared. So that confirmed our hypothesis. So we thought, we're done. We submitted it. We had a poster at the American Diabetes Association, and we submitted it this past June. It took a while, I told you. We submitted this past June to a journal. It got it got a desk reject. We got submitted another place, a desk reject, another place, an editorial desk reject. Finally, we submitted it back in October. It went out. Nice, strong diabetes journal. We got our comments back in December. They get rejected. We have a chance to revise and resubmit it. Okay, so what we're going to talk about now, because a lot of these EHR issues related to doing epidemiology or clinical research with EHR data came up with the reviewers. And that's what we're going to talk about. So what I'm going to do is I'm going to read to you the reviewer questions. We're not going to tell you how we answered them because we haven't, it's still under revise and resubmit. And Dustin is going to tell you the issues related to that. So the first couple of comments were, describe identification of fracture cases using the synthetic derivative. What ICD-9 codes were included? Were fractures identified or treated on an outpatient basis? Has the use of the synthetic derivative for fracture outcome been validated? Also, they said no data on validity of exposures and outcomes has been presented. This is of vital importance, especially with respect to fractures.
So two of the pieces there were, the first one was you need to be specific when you're selecting your subjects based on some kind of criteria. So you're picking fractures. Well, I can't just go to the EHR system and say, fractures. I have to be very specific, and I have to think critically about which ones I'm going to include and what I want to look for. Am I looking for just upper body, lower body, those kinds of things? And fracture, again, is just using as our example. I'm sure each of you who does this kind of research could come up with examples in your field. Did your data selection include all possible locations of the subjects that had fractures? So Vanderbilt's data included several of their off-site clinics, right? Just like our IDR system contains not just data here at the WVU system, it contains some other systems outside of Morgantown, right? So we need to know where are the data coming from? Are we getting ED data? Are we getting these kinds of things? So we have to understand what our data are, and we have to be specific about what we ask for. Okay, and we're going to come back to that when we talk about medications in a minute. You have to be very specific in your questions, because a general question like fractures or even diabetes, I want diabetic patients. Well, what do you mean, diabetic patients? Yes, go ahead. So the statement was about coding and the consistency of coding within the clinical system, and that's a specific comment we're going to make earlier. So you nailed right on top of the nail of the head of the nail, one of the big issues. So yes, but you need to be specific, and you have to be able to trust it. So we'll go to the next one. And so validation is key in all EHR systems. Validation, and that's a generic term. Okay, did you select all of the cases? When I say diabetic patients, did I get all the diabetic patients? Well, specifically for diabetes, there's a lot of work being going into creating algorithms because, as is mentioned, ICD-9 codes are sometimes entered in for diagnoses incorrectly. So there could be patients who are diabetic that don't get the ICD-9 code for diabetes put in the system correctly. Or diabetes is a bad example, but sometimes someone removes the diagnosis. Maybe they get control of their hypertension and they become not hypertensive anymore because of weight loss or something, right? So then they stop being hypertensive. Well, that may stay in their procedure codes or their diagnosis codes for a long time. Hypertension is still a bad example, but so you have to know what's in there, and you have to make sure you've selected the right subset of people. Go back up there. Is the data that you access the same as what was entered? We rely a lot on the clinicians and the people in the clinics that are entering data to enter everything in correctly. Right? If I'm going to say you're coding, I'm getting all the diabetic patients, well, every time somebody comes in, they need to have that diagnosis of diabetes in the coding. Or if you have a patient develops a new disease, it needs to be coded correctly. Right? We have to trust that. And as is pointed out, sometimes that's not true. Between 5 and 50% of codes are incorrect. And it determines on your individual EHR system. So you really need to think about what is going on with validation. How valid is your data? How good is it in terms of good from, is it actually, I'm jumping ahead, actually match the patient's experience? And does it reflect the reality?
So another question we had was, states that the baseline and updated mean A1C were tested. However, results reported are for most recent A1C, supplementary table and updated mean A1C. So that was actually, as I mentioned before, we decided that A1C, most recent, was not a good measure to use because so we ended up not using it, and I uploaded it by mistake. And the reviewer came back to it, but Dustin's going to comment on that.
Any kind of longitudinal study that you're going to use EHR data for are going to suffer from several issues. First is thinking of your baseline. When are you starting your study? Well, you could say it starts in 2009 when EPIC came to WVU. Okay, you could say that, but that might not actually reflect when patients go in and out of the cohort that you're imagining in your head. So you need to think critically about when is baseline for your longitudinal study. Is it onset of disease? Well, if it is, you need to make sure that you are satisfied that when you see that code appear first, that that's actually when that person developed that disease. Right? I hope you realize how much this is relying on the data and relying on the EHR itself. When is the end of follow-up? Well, for our study, we used their last observation in the synthetic derivative. These people could have had A1Cs somewhere else or could have had a fracture outside of our system. We don't know. We are limited to that amount of data. So our follow-up has a set date that's dependent on the system we're using. Otherwise, with this specific example, what we did for folks that had a fracture is if they did not have an A1C 6 months or so before their fracture, but had one 6 months after, or maybe up to 6 months after their fracture, we use that in our data set. Because what happens if you break your leg and they draw your A1C, but the lab doesn't come in for 2 days because it happens to be some kind of issue? So it's a couple of days after. Well, we wanted to capture that value for those that had fractures. But we could not do that for the folks that were our non-fracture cases because we used their very last observation that we occurred. So we had the potential of having differential exposure bias because we allowed something to happen after an event for one group but not for another group. Right? So that's one of the reasons we decided not to use the most recent A1C because of this issue, that we wanted to make sure our exposure groups were categorized the same. Okay?
So another question was, comment was, there's no data on drug use. This is very important, especially And highly medicated patients may receive more insulin and sulfonylurea and thus be more liable to hypoglycemia despite high A1C. Also, there's no hypertension in drugs against, it says hypertension in drugs against hypertension may also relate to risk of falls and fractures and should be included in analysis. And we didn't include any drug medications in our analysis.
So medications are a difficult quantity when looking at EHR data in general. And I want to say that there are a lot of research out there that's actually using the EHRs to look at drug misclassification. But for the purposes of research, you need to be really careful and understand your system when you talking about medications. Because one, it could be sensitive to time trends. So when did the Epic start collecting data on electronic prescriptions? Most of you might not be able to answer that question, but it's something you would probably need to know if you're going to use medication data in there, especially data that goes before Epic back to the old system, the MedSite system. You really need to know when things occurred and when did they start using it. Also, not all systems, and now some of the larger systems are good about this, but not all systems keep start and stop dates for medication. When was the person prescribed this medication? When did they stop taking it? Do you know that they actually took it during those time periods? Right. So more questions about medications, potentially missing medications. I know that there's a lot of people who go to the doctor that don't tell them all the medications they're taking because they get some at one physician and some at other, and they don't want to reveal everything. So you could potentially be missing medications when you pull these records. So, you know, I'm not saying don't use medications when you're doing these kind of research, but, you know, think critically about them. And then also, how many hypertension medications are there? I don't know, but I know I'm on 2. I know other people on 2, and none of them are the same. So if you want to go up to somebody who's getting the data from the EHR system and say, Matt Armistead, I would like to have all of the hypertension medications. He's going to go, give me a list, and you're going to go, okay, it's 600 medications, or whatever the number is. And that's just one example of a medication. So if you're going to say hypertension medication or diabetes medication, you have to be specific when you go into these systems. Otherwise, you're going to miss potential observations.
So the reason why we did not use medications in ours is we're doing time to event analysis, and our medications data was not time stamped. It only said the patient, this is their medication list. It didn't tell us when they started the medication, when they ended, if they ever ended it. They could have been off it for years. We don't know. So we decided we could not use that data. You're going to...
Going back to the statement we said earlier about coding, this is critical because a lot of times when you look at EHR systems, some systems output billing codes. Some output diagnoses codes, some output procedure codes, some output them all. What you want is to make sure they output all of them because, and I hope I'm getting this correct, in terms of the billing codes here, sometimes it only picks the top 10 ICD-9 codes that go into that system. Well, they might have had 30 or 40 ICD-9 codes that were corresponded with that visit, but if it wasn't the most money-generating code, it wouldn't make it into that list. So if you're only using billing codes, you immediately may have biased away some of the more less expensive diagnoses. So they don't often capture the entire picture of the patient experience. Sometimes codes will come and go off of a patient's record. So if I'm looking longitudinally, there'll be a diabetes code here, but they'll come back and not be diabetic then, and then be diabetic again. Well, you know they're diabetic throughout, but what about other types of codes, right? I'm not a clinician, I'm not a physician, so the examples I have are not very good. But codes come and go, and so you have to be clear about whether or not that person actually had that diagnosis during the time period you're interested in. The first appearance of a code may not correspond to the onset of a condition. This is one of the bigger issues, especially somewhere like WVU medicine, where a lot of times patients will come here after going to some other system. So they got so quote unquote sicker, and so they came up to the big hospital. And so they may have had a diagnosis of something long ago, but they entered our system and it says, oh, they were diagnosed first with this disease or this this issue on this date. Well, that's not exactly true to the patient experience. So we have to think about these things because codes, we're making a huge assumption that the codes represent the patient's experience and the patient's truth, and that may or may not be the case. So we need to think critically.
Did the clinic manage all patients from the catchment area or say only the more severe cases?
How many hospitals and clinics are in Morgantown? Alone. It's not one. It's not two. It's not all the WVU system. We have Mon General and their clinics, Health Right, these other systems. They're not all represented in our EHR. So to say that our EHR represents Morgantown may be an unfair assumption and an invalid assumption to the data. So, but we want to know what systems are in your EHR. What, are they a composite like the IDR, which is becoming more and more of a composite of more than just one system? Vanderbilt's was all Vanderbilt-related clinics, which is a lot of clinics in that area. So they said they had a large catchment area. But still, there may have been demographic differences between the patients that went to Vanderbilt's system and not Vanderbilt's system. The largest one may be SES. It may be proximity. They can't get into Vanderbilt if you don't have good modes of transportation, but live in the outskirts. Can't get into those clinics. So what kind of patients are represented? Can you go to the next slide and make sure I get all the points? Yeah. So what population your EHR represents is a key component to your analysis and what statements you can make at the end of the day. Also, could you consider it to be a random sample of the true population that you're interested in? If you're considering all patients who have diabetes, could the sample from our EHR be considered a random sample of all diabetic patients? It deserves thought, because a lot of the statistical inference relies on these things being random samples from some population of interest. And if there's some systematic difference, like you're only using data from a clinic that sees high-risk patients, then that might not represent all diabetic patients. But you can always say, my population is the most at-risk patients. But that change is a very important change that needs to be thought of before you try to start publishing or presenting your paper, because you want to accurately represent the work that you have done and the population of interest. Yes, sir.
I believe so, but I can't answer 100%.
The question was, does the Vanderbilt, the synthetic derivative include financial data? I'm not sure. I don't know that it does, but I'm not exactly sure.
Yeah.
I don't know. We did not use any financial data in our study.
Yeah, it's not in a synthetic derivative for sure. Yeah, but the thing about, I want to come back to, they asked, did you only see the sickest patients? And that's an important question because it is a hospital. I mean, it's a healthcare center too, and you see regular patients on an ongoing basis just for their general care, but it's also a hospital. Are you seeing, or is it that a physician does not, when a patient starts getting sicker, I don't want to treat you anymore, I think you should go be treated here? Is that what we're getting, just sicker patients? And that's something you need to think about as well, and I don't know the answer to that. Were cases consecutive?
So what kind of the study that you decide to run with the EHR data is critical to answering a lot of these questions. Are you going to run a cohort study? Ours was much more of a cohort study. We selected a group of patients based on our criteria and then looked at all of the data we had for them up until a certain time point. So it's a cohort study, like a mock prospective study. Are you doing a case control study? You pick all the patients that have a certain criteria this day, at this time, and then you look back and try to find their exposure. Is that the kind of study you're doing? Well, that requires different kinds of thoughts with the EHR data. Are you using cross-sectional study? So I'm only looking at patients that came in the month of January in 2015. I'm only looking at data that's available at that point in time. Again, that's a different kind of study design. It causes a different kind of relationship working with the EHR system and the data that you would need to answer those questions. So study design is a very important part of the whole process. What are you trying to do and what is your design meant to do and the question you're trying to answer?
The authors state that data collection started in the early 90s. What were the specific dates of start?
if you're going to use EHR data and do this kind of research, you need to, if you don't know it off the top of your head, that's fine. What you need to do is have access to this kind of information so that you can put this into your research. Right? You need to know, when did you start collecting the data, especially if you're collecting certain kinds of data. You need to know what systems are included. Can anybody tell me, other than the two guys sitting in the middle, what systems are included in Epic and which ones aren't here just in Ruby? What if I wanted dental data from the dental clinics here? Is it in Epic? No, it's not. So you need to know which systems are included and which ones are not. And in fact, I think there's other systems here at the hospital that are in the, on the medicine side of things that are not included. So you want to find out what data are available. What data are you excluding just by using this kind of EHR? You need to know those kinds of answers, or at least know where to find the answers. Okay.
Suggest adding BMI to the models for the subset of individuals with data, since it is a strong predictor of fracture, and this would be a very unique analysis.
So this is one of the main points I want you all to take from this, and I think Baqiyyah agrees. The data structure, it can be non-trivial. So the data that we're using in the EHR, the structure of that is very non-trivial. The analysis data, that's an issue and that's work on your end, but the data that you get is non-trivial. EHR studies are not randomized trials. If we were running a randomized trial and you brought in patients and you picked what they were going to do, and then you said, I'm going to collect X, Y, and Z from every patient at months 1, 3, 6, whatever, you're going to have a lot of data, a lot of access to these patients. EHRs don't do that. We rely on people to come to our clinics, to come to the hospital, come to the ED. And they don't randomly come here. Right? The ambulance doesn't flip a coin when it's driving down the street going, am I going to Ruby or am I going to Mongen? At least I hope not. So this is not a randomized trial. So there's a lot of analytical considerations that need to be made. You have to adjust for confounders. Because if you're going to compare diabetics and non-diabetics, they're probably not balanced across gender, age, any of these other covariates that might be important to your outcome. Right? You also have missing data. Oh, do you have missing data? Just in our little example, we had 24% of the people who are missing BMI. Okay? Weight should be taken at most clinic visits. And it is, but sometimes it doesn't get into the system. And this is a fact. This is probably a relic of some of the older systems. But it could still be true for our system, or the system you're interested in using. And that's just one thing. What if you're trying to measure patients and you're wanting to look at somebody's cholesterol over time? How many times do you get your lipid panel read when you go to the doctor? It really varies on what your illnesses are and what the doctor's trying to do. So you may have a patient that comes in, it meets all your inclusion criteria, but there's not one lipid panel at all in the entire system for this patient. So then you have to exclude that patient from your study because they're missing that data. Okay? So missing data is an enormous problem. And I can tell you that the biostats and epi fields or groups are getting together. There was a conference a year and a half ago that Baqiyyah went to that was just for how to handle EHR analysis by epidemiologists and biostatisticians. And one of the main points was, what do you do about missing data? Because we know it existed, but we don't have it. And it happens a lot in EHR studies, especially longitudinal studies. One way you can get around that is doing what we call sensitivity analysis. If you'll go to the next slide. So what we did was we took the second column is the main analysis but we conditioned it only on those that had BMI measurements. And the second, right? That's what that.
Right. So this first one, these are people, we didn't adjust for their BMI, but everyone had a BMI measurement. That was great. It was not a zero BMI. But in this population, these are the people who had a BMI measurement as well, but we also adjusted for it. And so we wanted. So they're the same population. No, so do you notice here that when we have, I take that back. I'm sorry. This is the entire population. Right here. Some of these people, 24% of this population have missing data on BMI. Right here, this is the same population that everyone has complete data on BMI. Do you see how the values change here for A1C?
That's because these are two very different populations of people.
Right. It's and the missing is not at random. So what happens is that we start here with about 19% of those in these two categories have missing data. By the time we get up here, we have even greater percent. We're up to like 25 to 30% with missing data here on 9%, which might explain why. Remember, BMI was a surrogate for the relative patient-provider interaction. It might explain why, when you account for that, that increased risk associated with a high A1C disappeared.
So this would be considered a sensitivity analysis run only in a subset of our population. But understand that these two, I can't really compare these two populations. These are two people that differ on a factor that's very important, BMI, potentially obesity, if we want to consider it that way. And so I can't just say, oh, this is the far right column is now my new population. Well, you've restricted it to even more. And you can do that analysis, but you have to be clear in your write-up and your presentation that you restricted it very greatly to having had at least one BMI measurement in your data.
So we're finished with that paper. We're going to move on now to the integrated data repository here, what we use here.
So that was an example of some research we've done with EHRs and the issues that's come up with us. One of the things we want to do briefly is show you what's becoming available to the WVCTSI members and what are the things that we're doing as our validation team. So I just want to list, the validation team consists of Baqiyyah and myself, Matt Armistead, and Mike Denny, who is one of our lead informaticists, who's actually the first author of this paper because he is the man with the knowledge that helped build this system. So him and another gentleman. So the IDR, the Integrated Data Repository, takes data from our systems and puts them together through what's called the extract, transform, and load process, and puts also through the MedSite data, so data that existed prior to Epic. So this goes all the way back to, what was the year? 2003? 94. I was close. For certain types of data. But see, that's the key. If you want to know what data you're getting, and Matt sent me the list of when all the dates became active, I just can't remember it. You have to know, when can I get lab data? When can I get data from the ED? Those kinds of things. You need to understand what dates are available. The IDR takes both of these systems and puts them together in a user interface that a user can request access to. And then once that occurs, then you can request the data be given to you in a de-identified format or identified based off of what protocol you need. Yes, sir. So the question was about the pathology system, and as far as I know, it's not part of the IDR at this point. I don't know what the discussions are there. I'm not part of that. I'll refer you to someone else.
You want to take the mic up too? I don't know.
Okay.
You got it?
Yeah,
okay.
Thank you. And so if you want to do this kind of research, you can go through this system. And part of our job has been to validate this system. And that validation is through the ETL process. So that makes sure that what's in Epic that the clinicians can see at their desk matches what the researcher would see when they request the data from our system. And we found that...
So this is a validation project we did, and this is what we're talking about here.
So even with our system, we were able to we found several little issues. One was race that we talked about. It turns out that in that particular instance, it was empty for the time that we pulled the data, but then later that race had been recorded for that person, so that when we tried to validate it, they said, oh, you have a missing data, but we have a value. And it turns out that it was recorded in the EMR between the two time pulls. But luckily, what the crux of this is that even though we had some issues, which are all very, very minor and have been fixed for the most part, we're 100% valid. What you see at your end as a clinician and what we would be able to provide to you from the WVCTSI, from this system, is 100% the same. So we can help you get the data that you have. Now, this has not been edited for research, such as the SD system that we showed you earlier. that would be something we would be working on later to try to hopefully get to that point where we've got 61 people working in the background for these kinds of things. We'll tell Dr. Hodder that that's the request that we have for the next round. So
just, even though the system was valid, it's important to realize that the choices made through the extracting that data and bringing it to you may, a part of that process may affect the researcher query results. So, for example, you might think that you're getting one thing, that you're requesting one thing, but you're actually getting something else. And it's not a mistake, it's just you need to be aware that, make sure what you think you're asking for is what you're getting. For example,
one of the things we found was that the person, we were looking for a lab value, and we found the lab value, but the dates didn't match because we pulled order date, but then the person on the other end was looking at fill date. So when was the lab performed? And it turns out that the order was late in the evening, and it was filled the next day, so when you looked at date, they didn't match. So that's a very simple thing that happens. Things happen at night, but don't get filled to the next day. So the date may be an issue. So you want to consider maybe looking plus or minus a day to try to find values of interest. But that all goes back to knowing the system that you're using, understanding that there's decisions being made and there's work being put in before you actually even touch the data.
In conclusion, electronic health records can be used for cost-efficient research to the researcher in both large and small studies, but there are several issues that need to be addressed when you're performing these studies. And you might want to consider consulting with one of us before designing your study, when you're designing your study.
Any questions? I'm actually going to walk the mic up this time so that everyone can hear these questions.
Thank you. I think, not really a question, but a comment, because another consideration that's really important, I think, is with the actual lab values. For example, like when you're looking at potassium levels, how many times does it come back hemolyzed? So if you try to use a potassium value in a study, it's not even the right value. Or when, for example, A1C or any lab value or any lab test, you have to account for, say, the machine that's doing it, because there's going to be some variability in the data itself with the value. So, I mean, those things are going to be very difficult to capture. And then also when it comes to when does the lab transition from using one machine to another machine to a more accurate machine. So that stuff also needs to be considered.
Thank you.
Yes, those are all great points, and I can tell you at the study that we performed, we actually had a person that had an A1C value of 100 and something. I can't remember the exact number. So we excluded that value because it was obviously physically impossible. The question was, how much does Vanderbilt charge to use this system?
So when I first came here, I still had 6 months access to my email and everything, so I was able to get the data still without having to pay anything. Now that when I'm requesting data, I think they've raised it to, it's about $90 an hour if they have to do the query for you and collect the data for you.
So
but that's what they were charging for. When we got the meds, we purchased meds because it was a while after I left. They were charging us, I think it was $80 or $90 an hour. It only took about 3 hours of time, but for larger data sets, depending on the amount of work, I would say roughly around $100 an hour.
So hopefully.
We are considering 4 hours for free, and then our CTSI is considering doing what other places do, which is 4 hours of work for free for the researchers, and then charging certainly those who have grants, charging their grant for our programmer time. Well, for anybody, but we only do work for CTSI members, and that's a free membership, easy to get.
Any other questions? Okay.
Thank you. Oh, Chuck has one.
One more.
Sorry. So one comment at the national meeting, and I mentioned this in one of our informatics gatherings, but there was a big discussion about EMR loyalty, and so one of the researchers in Boston is going to be publishing their analysis of their large research data set of how you may be able to, rather than taking everybody with, say, a code of interest, in this case a diabetes code, taking, searching through their loyal patients, and that by loyalty meaning patients who get a majority of their care at Harvard, rather than we're just driving through Boston one day and got hit and we're seen one time at Harvard. And so maybe in the future we would all carve out our loyal patients and then do analyses on them. The fact that you have at least 2 encounters in this study, and hemoglobin A1Cs are usually only measured among loyal patients because that's a chronic care PCP, patient and their primary doctor kind of diagnosis and care treatment kind of thing. These patients are already sort of loyal, but it's something we're thinking about for other projects.
Thank you.
Hi, I'm Matt Armistead, and if you're interested in working with the IDR here at WVU, feel free to email me if you have any questions about what data you can pull out of there, or if you're interested in making a data request. I strongly recommend talking to Dr. Conway or Dr. Long before meeting with me, just to kind of get an idea about just how you can leverage electronic medical records for your study. But once you have study ready, please feel free to contact me and we can move forward in pulling that data for you.
Yeah, yes. And just along those lines, we are, the CRDEB, CREDEB group, we are available to any researcher within the CTSI or without it who's doing any kind of research that needs epi or biostat support, and specifically with these EHR type questions. So please feel free to come and see us if you have any kind of research that needs our expertise.
Great. Thank you very much.